My name is Daniel Berman. I'm a physician at Cedars-Sinai Medical Center in Los Angeles, where I'm the director of cardiac imaging. It's my pleasure to be here at the annual meeting of the International Academy of Cardiology. This is its World Congress on Heart Disease, and it's the 23rd annual scientific sessions. It's a phenomenal meeting with a great organizer, Dr. Kimchi. It has brought together this time speakers from 41 different countries around the world. It's an opportunity for people in a very relaxed environment to have the exchange of the most recent scientific breakthroughs and an exchange with open questions and answers and plenty of time to interact with faculty. My talk was on the use of coronary CT angiography and how it gives us information beyond stenosis, dealing with ischemia and with plaque. Now, stenosis itself is very important, and that's what I emphasized in my talk. If patients have critical left main coronary artery disease, we need to know about it, and that really does guide our management, as do other stenosis findings. On the basis of stenosis alone, trials have shown that CT angiography is highly effective in the management of patients and potentially, as shown in the Scott Hart trial, in reducing cardiac events. But beyond looking at stenosis, CT can look at functional variables. In the area of ischemia, CT perfusion imaging can be performed, doing pharmacologic stress and then giving an injection of contrast during the pharmacologic stress, and looking for perfusion defects with the arrival of the contrast in the heart that are similar to what we see with nuclear scanning. And in fact, you can do this both in a static mode, as in common nuclear with SPECT, or in a dynamic mode where your absolute blood flow is measured as it is with PET. A more accessible approach is to use what's called fractional flow reserve by CT, or FFRCT. This technique uses a standardly acquired CT that with computational fluid dynamics is able to predict the FFR measurements that are obtained in the cath lab. It's done with no additional radiation, no additional injection of contrast, no pharmacologic stress. With FFRCT, the drawbacks are you need to send the data out to a company that performs the analysis, heart flow, and you need to, there is very considerable expense associated with it. The FFRCT has been shown in multiple trials now to correlate highly with FFR in the cath lab. The most recent of these large trials was the NXT trial, which showed that there was higher accuracy in predicting FFR in the cath lab than by stenosis, either by CT or even stenosis in the cath lab itself. So FFRCT is very accurate, or is shown to be accurate in predicting FFR in the cath lab, and particularly important is it's highly sensitive. So you can take a coronary CT stenosis, and if the FFRCT is completely negative, the likelihood of having an FFR positive lesion in the cath lab is quite low. Recent developments have shown that even machine learning approaches to measuring CT FFR might be something that is used widely in the future. Perhaps most excitingly with CT is its use in assessing coronary plaque. With standard conventional angiography, we can't assess plaque with OCT or IVUS in the cath lab. We can, but those are invasive technologies. So plaque is really the source of the problems in coronary in coronary artery disease. And with CT, many of the high-risk plaque features that give us an accurate prediction of subsequent events can be analyzed. These features include the plaque characteristics, including low attenuation plaque, that's the lipid core, the overall volume of the non-calcified plaque, which gives us the index of positive remodeling, outward bulging of the artery, large plaque, which we know is associated with increased risk, and even from the plaque characteristics, a prediction of ischemia. So it's been demonstrated widely from many groups, including our own, that the CT plaque characteristics are predictive of mortality, they're predictive of other adverse outcomes, and they are predictive of ischemia. These approaches are going to be put together most widely by using machine learning. So if I just summarize for a second, CT, coronary CTA, is a disruptive technology. It's going to grow dramatically. It has a tremendous volume of information, with types of information about the coronary vasculature and the plaques associated with them. Plaque imaging and the characterization of plaque with CT is likely to become one of the important focuses in the future, allowing us to not only characterize risk very effectively, but also to monitor therapy in looking at actual shrinking of plaques that occur over time with LDL lowering and other therapeutic approaches.